Good evening and welcome to another season of Doctors on Call. I'm Dr. Ray Christensen from the Department of Family Medicine and Community Health at the University of Minnesota Medical School in Duluth. Tonight's first program of the new season is on heart problems. We will be glad to take your calls on heart attacks, prevention, diagnosis, and treatment. The success of this program is very dependent upon you, the viewer. Please call in your questions and we will do our best to address them. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Jeff Adams, an ER physician with Essentia Health and a faculty member at the Department of Family Medicine and Community Health at the University of Minnesota Medical School, Duluth. Excuse me. Dr. Stephen Huddleston, a cardiothoracic surgeon with St. Luke's Cardiothoracic Surgery Associates, and Dr. Antonio Laudito, a cardiothoracic surgeon with Essentia Health. Our medical students answering the phones tonight are Brian Berglund from Lauderdale, Minnesota, Tyler Gettle from St. Clair, Minnesota, and Peter Hughes from Mankato. And now on to tonight's program on heart problems. Dr. Adams, your work down in the emergency room gives you the opportunity to see many heart attacks when they first come in and heart problems. Could you give us a little idea of what you expect to see in someone who has chest pain from a heart, or things that would indicate that they may be having a heart attack?
Well, that's an interesting question. We all have seen the TV show where the middle-aged fellow is clutching his chest and saying, I think I'm going to die, and they have excruciating pain. And to tell you the truth, it doesn't require much medical knowledge to figure that that person may well be having a heart attack. The difficult for us is screening out all the people that have other types of chest pain or possibly no chest pain at all. We do know that a lot of the elderly people can just be dizzy or have a fainting spell and have symptoms, and that turn out to be a heart attack. Shortness of breath by itself can also be a heart attack. So the problem is not so much the obvious chest pain, the crushing chest pain that most people would show up in the ER because they do indeed feel like they're going to die. But it's the people that have indigestion or heartburn, and they haven't really kept track of it. It's kind of like their old reflux they used to have, but maybe a little bit different. They notice that this time it happens when they went up the steps. It used to happen after a meal, but it's a lot like the reflux. They don't call it pain, they call it heartburn, or they call it burning or indigestion, or they may say, I feel short of breath or very fatigued. And so it's difficult to pick up the people that have the atypical symptoms, we call it, and that can be the young, the old, the female. All are not the classic picture that we imagine with chest pain.
Very good, thank you. Incidentally, should you guys feel that it's necessary, we have a heart here for you tonight, too. Dr. Huddleston, what's happening with a heart attack?
Well, I think to understand what's happening with a heart attack, first you need to understand and think a little bit about what the function of the heart is. So your heart is a very muscular organ that sits in your chest, and it fills up with blood, and then it pumps that blood out to your body. And that blood is full of oxygen and nutrients so that your organs can do all the work that they need to do. The first blood that comes out of the heart and is pumped out into this main artery coming out of the heart here, called the aorta, the first blood that comes out actually returns and goes directly back to the heart to feed the heart muscle itself. And this blood travels through small blood vessels here, small arteries, that feed the heart muscle. Unfortunately, for many different reasons, blockages can occur in these blood vessels. And when there's a blockage in one of these blood vessels, it can either reduce the amount of oxygen and nutrients that get to the heart muscle, or it can clot off altogether, and a blood clot can form in that artery, and you can get no blood flow down there. And that leads to the two different types of heart attacks. One is where there's decreased blood flow or a lack of blood flow, and the heart won't work well during that time. And the other more severe type of heart attack is when the artery is completely blocked and there's no blood flow to that part of the heart, and that's really an emergency. So that's what a heart attack is.
Thank you. Dr. Laudito, what would you do? What's the next step? Those of us that practice in rural areas and so on know that we need to have our hearts in real fast. They need to get to the cath lab, and there's a lot of things that can be done, and you people take care of those kind of things. Can you tell us some of the next steps?
Following Steve, very nice introduction. What I would like to have our viewer understanding the time is crucial in presence of a heart problem due to coronary obstruction. It's crucial because time, as the interventional cardiologist would say, time is muscle. Means that we have a specific timing schedule to get this patient to our cardiac cath labs, where identification of the obstruction can be performed, and our interventional cardiology are extremely skilled in placing the appropriate management strategies, meaning a stent, a ballooning the obstruction, or in the appropriate case, requesting a surgeon intervention to do a revascularization, meaning the obstruction is in such a critical area or is such a critical condition that just surgery, and for surgery we mean conduit to bypass the obstruction. In this, the heart anatomically as a two coronary, but surgically speaking as a three coronary system, because the left one immediately divides in the most important left anterior descending, the circumflex, and the right coronary artery. This is the third one, surgically speaking. So when the doctor at the periphery realized that there is even the suspicious of this, immediate attention, because the rule is that time is muscle. The more you wait, the more muscle is jeopardizing and damage.
And both you and Dr. Huddleston then do that bypass surgery type procedures.
And this is something that I'm very excited about for the community of Duluth, because I'm a strong believer of the arterial coronary reconstruction. And this is, of course, there are meetings just organized on this, but patients need to understand, need to be informed by the physician the quality of the conduit. Unfortunately, bypass surgery is a palliative surgery. Palliative surgery means we do not treat the cause. We just temporarily find the solution. So it's very important in this that this temporary solution lasts as long as possible. Nowadays, me and Steve are seeing very young patients arriving to our office or even emergency room, and you cannot follow the usual traditional rules using all conduits. So nowadays the standard of care is arterial coronary reconstruction, and when I mean arterial, I mean double mammary. A young patient, when I say a young patient, patient less than 65 years old, should always be considered for a double mammary reconstruction in case of coronary artery bypass.
Steve, comments?
I think that's a great answer. I think the type of revascularization depends on the situation. If a patient just has a blockage of one artery and they have symptoms from that, then they may be just treated with medical treatment and stents. In the situation where you have blockage of the main blood vessel feeding the heart, the left main coronary artery, or if you have blockage of all three blood vessels, then the most durable and effective way to provide new blood flow to the heart is to do bypass surgery. And I agree 100% with Dr. Laudito that the best way to do that, if possible, is with using both of the arteries from the inside of the chest wall. There are two types of ways to get new blood flow to the heart. One using the arteries from the inside of the chest wall, and then you can also use veins from the leg. The most important discovery in bypass surgery has been using one of the arteries from the inside of the chest wall, the internal mammary artery on the left side, and that will help the patient live longer, decrease their chances of having a heart attack, and decrease their chances of having chest pain. But through the years, we have also learned that using the mammary artery on the other side will provide some survival benefit far down the line, 15, 20 years down the line. So in younger patients especially, that's very important.
I appreciate both of your explanations. I think it was worthwhile taking some time just to go through what you do in the revascularization. And the conduit is opening and making the vessel bigger is what I understand. So Jeff, just a quick switch. Chest pain, what's different? What are the signs of a heart attack in a woman versus a man? And as you went through before, you kind of broadened things out. Do you want to speak specifically to the female gender?
Well, it's hard. The research isn't as strong in women as it is for men, and so we don't know quite as much. Plus, the risk of heart disease in women is less, and so more women are going to turn out to be falsely positive in our evaluation, and so we have to screen a little bit closer to try to find these women that actually do have heart disease. The same risk factors apply if they're a smoker, if they have a strong family history, if they have high cholesterol, if they have what they call syndrome X, or what they call heavy-set body habitus, that type of thing, pre-diabetic. Those people are at greater risk, and so we would screen them closer. If you don't have the risk factors, you may present with the same symptoms. So sometimes the background does help us to know if we have to be more or less concerned with the symptoms the woman presents with, because they may not present with chest pain. The pain they present with may be atypical, meaning it might feel more like indigestion or an achiness, or it might even bother them when they take a breath in, which we usually don't think of as being heart disease. They may not have much in the way of chest pain. They may just have shortness of breath or fatigue. They may have lightheaded spells or dizziness or fainting spells. But the number of women that present with the classic symptoms of chest pain is much less, I can tell you, than that with men. What they replace it with is much more vague and encompasses a much larger group of people that actually don't have heart disease.
Are there specific surgical challenges in operating on the smaller chest of the female versus the male?
There can be in smaller patients. Every patient's different, and every patient's anatomy will be a little bit different and present different challenges, and there are certainly some that are easier than others. I wouldn't say that operating on female patients who may typically be smaller is necessarily that different, though. It's fairly similar, really.
Next question is, and we talked about this a little bit before we came out. The question starts out, what causes missed beats? And then the slash is fibrillation. So we know that with heart disease, and sometimes without heart disease, there's extra beats and missed beats. And we had talked earlier about atrial fibrillation. Jeff, what is atrial fibrillation?
Unfortunately, I'm a personal experience of atrial fibrillation because I went into it myself about a year or so ago. And that 20% that you lose with atrial fibrillation, cardiac output drops at 20%. Affected me, so every time I ran up a hill, I got dizzy. So it's not totally benign. A lot of people do real well with atrial fibrillation, and you don't have to convert them out, and sometimes you can't. But atrial fibrillation is basically the atrium no longer controls the rhythm of the heart, and so the atrium basically sits there and shudders and shakes like a ball of earthworms, and firing off multiple different electrical charges, and the ventricle kind of picks and chooses which one it responds to. So the ventricle, which is the pump system of the heart, beats irregularly. 1, 2, 3, 4, 5, 1, 2. And the only big disadvantage, besides reducing your ability to run marathons possibly, is you're more prone to having things like stroke and stuff like that. And so they have a strong indication to having what they call blood thinners, people call them, or things that make your blood less sticky, the common one being warfarin. And so many people in atrial fibrillation, unless you're prone to falls or some other indication not to, get placed on the drug called warfarin to keep your blood from clotting inappropriately.
So, gentlemen, atrial fibrillation is something that you deal with. I know that the electrical phys cardiologists also slide tubes up and do things with it. But what do you do with it in cardiovascular surgery? And can you show us where you work?
I'm very pleased to have the public listening us about atrial fibrillation that has very nicely Jeff expressed. There is a problem with the atria. The atria, left and right, and mostly the left, I would say 98% as the data, the left atrium, are the collecting chamber of the heart. The two ventricles, the right and the left, are the pumping chamber. So this collecting chamber, mainly the left atrium, is responsible to give the rhythm to the heart together with the right atrium. Now, the atrial fibrillation is when these, as Jeff was saying, contract in an abnormal way. And nowadays, atrial fibrillation is not like 20 years ago. We achieve an understanding of this disease much more deeper. We realize that is a major problem of our society. People need to be addressed and treated because it's a problem, is a disease that will create, as Jeff was mentioning, stroke, will create a marker for other diseases. What do we do? There are the famous treatment that my close friend and mentor, Dr. Jim Cox, devised, what is called Maze procedure, is a procedure that nowadays doesn't get performed. And essentially what we do, we are going to create some scar. We create scar on the posterior, surgically speaking, on the posterior aspect of this left chamber of the heart, the atrium, and these scars are kind of re-establishing pathway in the heart when the scar mature. And a very important component of the surgical treatment of atrial fibrillation is the treatment of the left atrial appendage. That is a chamber very important when we grow up in our evolution, but for hormonal secretion. But in adult patient is just a function, not appropriately represented here, but essentially this left atrial appendage is a little chamber that when the heart switch back and forth from normal rhythm in atrial fibrillation, this chamber collect blood with lower velocity, clots formation is present, and when the atrium is back in the normal sinus, this clot is dislodged and can be creating a stroke, embolic event to extremity, to an organ. And that has a dramatic consequence, this kind of event. And so as a surgery, we offer the formation of this scar to reestablish discipline inside the heart, and we close the left atrial appendage that is the source in 95%, according to studies, of the stroke created by atrial fibrillation.
Thank you. Steve, a couple of questions have come up on valves. And one is a valve, when should a valve be replaced, and is that something that you as a cardiovascular surgeon, so let's pick aortic stenosis because that kind of is probably one of the commonest, or mitral, either one. What happens and when do you need to operate? Okay. And how does that cause heart failure?
That's a great question. So valves are like one-way doors in the heart. So the heart fills up with blood, and then the heart contracts and ejects blood out into this big blood vessel that carries it out to your organs. If there was no way to prevent the blood from rushing back into the heart, then the heart would fill up with the blood again, and the blood would not just stay flowing forward. So you have valves in the heart that perform the function of preventing the blood from flowing backwards, and they act like one-way doors. There's one important valve right where the blood exits the heart here in the aorta called the aortic valve. And the aortic valve typically can have two types of problems. Either the valve can develop very hard calcifications on it. It can become thickened, and then it does not open well. And that causes the heart to have to beat stronger to pump the blood out through the valve that is becoming obstructed. The other type of problem you can get with the aortic valve is the valve can be leaky, so to speak, where the blood is pumped out, but then the valve doesn't prevent it from flowing backwards into the heart again. In the instance where you have blockage of the aortic valve, where the aortic valve has become thickened and scarred with calcification, the only treatment when this becomes severe is to remove the valve and replace it with a new valve. That valve can be made of mechanical parts or can be made of parts from animals. And that surgery involves going on a heart-lung bypass machine, stopping the heart, opening up the aorta right here, and then cutting out the thickened and calcified aortic valve and replacing it with a new valve. The other type of situation you can develop where you have a leaky valve, which is not necessarily thickened and scarred with calcification. In that situation, we don't operate usually unless the muscular part of the heart starts to enlarge. And that indicates that the heart is having trouble with that backwards leaking from the valve. And in that instance, we perform the same operation. There are a few rare instances where you can repair or preserve the aortic valve, but those are pretty special circumstances. And far and away, the most common treatment for problems with the aortic valve is to replace it.
Great, thank you. I'm going to move on to some other questions. We need to get some medical questions in here. Jeff, what's the difference between good cholesterol, bad cholesterol, and triglycerides?
Good cholesterol is considered what they call HDLs, which are a particular type of cholesterol. And if you exercise and have a good genetic predisposition, you'll have high HDLs, but exercise seems to go along well with that. LDLs are considered the bad cholesterol. They're the ones that people try to get very low levels on. And then there's what they call total cholesterol. When you're around age 35 or so, unless you have high risk, they recommend getting your total cholesterol and your HDLs checked once to see if they're elevated. And if they are, there's some evidence that going on medications such as statins is a group of drugs that they talk about benefit you. And they try to first improve your diet, and reducing your cholesterol exposure and your eating healthy is a good idea. And if it doesn't control your cholesterol enough, then they recommend going on a statin or a medication like that. So there's three broad ones. There's total cholesterol that they look at. There's LDLs, which are the light cholesterols, and HDLs, which are, quote, the good cholesterols that they talk about.
So if you can't take a statin, what about omega-3s? Are they helpful?
No comment. There's some stuff.
Well, there's
out
some
there.
discussion in the literature
Yes,
that's
there's-
just coming out.
Yeah, there's some, unfortunately, American literature oftentimes gets really big on one thing, and then the more research, the more people on a particular drug, and the more times they look at it, it returns to the norm. So oftentimes there's a peak, and very enthusiastic, and over time it gradually returns to more of a baseline where there's maybe a little improvement, but maybe not as much as we thought. And some of the dietary changes and stuff maybe are that way. I don't have any specific information. I know that they've talked about fish oil lately as maybe not as useful as once thought and stuff. And I don't know. I think eating a healthy diet and trying to moderate would be a reasonable idea.
Are PVCs serious? First of all, are PVCs common? And are they a precursor to something serious? I'll get the question right here. So PVCs, premature ventricular contractions, extra heartbeats.
Go ahead.
Always we need to identify who is having this problem. It's a completely different scenario between a teenager and 60, 50 years old. It's very important that there is an approach to the patient in a complex assessment by a physician, by a specialist, and it's very important that these need to be assessing the age of the patient, what kind of risk factor. Can be something normal, can be something extremely important to assess.
Very good. Dr. Huddleston, how long until an aortic aneurysm ruptures? And let's talk in the chest.
So an aortic aneurysm is when you have enlargement of the main blood vessel that comes out of the heart, called the aorta. You can think of it kind of like an inner tube on a tire. And you've seen when an inner tube on a tire becomes weakened or develops a defect, it starts to bulge out and enlarge. And that's sort of similar to what happens with aortic aneurysms. The aorta begins to weaken and enlarge. The risk of that, there are two complications that can occur whenever you develop an aortic aneurysm. One is dissection, where the layers of the aorta start to come apart. The other is rupture. And the risk of both of those depends on the size of the aneurysm. So it has to be followed over time to determine if it's enlarging and to determine if it's reached a critical size.
Thank you. This was an interesting discussion tonight. We spent quite a bit of time on cardiovascular surgery and atrial fibrillation, very important subjects. We have many questions that were not answered, but I really want to thank our panelists, Dr. Jeff Adams, Dr. Stephen Huddleston, and Dr. Antonio Laudito, and our medical students, Brian Berglund, Tyler Gettle, and Peter Hughes. Please join Dr. Alan Johns for a program next week on infectious disease and immunization, when his panelists will be Dr. Timothy Burke, Dr. Ken Ripp, and Dr. Andrew Thompson. Thank you for watching. Good night.